Hi, I'm Massimiliano Di Pietro. I'm a senior clinical investigator scientist at the Early Cancer Institute, University of Cambridge, and consultant gastroenterologist at Cambridge University Hospital.
Hello, my name is Dr. Mathew Vithayathil, and I'm a gastroenterology clinical research fellow from the United Kingdom.
We would like to tell you about a study recently published in Endoscopy Journal and entitled Longer Procedural Time Increases the Dysplasia Detection Rate During Endoscopic Surveillance of Barrett's Esophagus. Esophageal adenocarcinoma is a cancer with very poor prognosis, with less than 20% patients alive at 5 years from diagnosis. Barrett's esophagus is the only known precursor condition to esophageal adenocarcinoma, and for this reason, gastroenterology guidelines recommend endoscopic surveillance for patients with Barrett's esophagus. Endoscopic surveillance involves thorough inspection of the esophageal mucosa and systematic random biopsies according to the Seattle protocol, which entails 4 biopsies every 2 centimeters in the Barrett's esophagus segment. Endoscopic surveillance allows early detection of cancer and dysplasia, which have remarkable better prognosis than advanced cancer and can be cured endoscopically. However, endoscopic surveillance is time-consuming and poorly performed in clinical practice, particularly for long segment of Barrett's, which are also associated with higher cancer risk. And one of the main reasons for poor adherence to guidelines recommendations in practice is that time allocation in endoscopy for Barrett's surveillance is often suboptimal and does not allow enough time for thorough inspection and multiple biopsies. There's little evidence in the literature about how long endoscopic surveillance procedure should last. Therefore, we have performed a prospective study with the aim to determine the optimal duration of Barrett surveillance endoscopic procedures and also correlate procedural time with the dysplasia detection rate.
So our study showed that the median procedural time required to perform adequate inspection and Seattle protocol sampling was 16.5 minutes, increasing to 22 minutes for patients with Barrett's length greater than 5 centimeters. We found longer procedural time increased dysplasia detection from Seattle protocol biopsies. Furthermore, for Barrett's length greater than 5 centimeters, longer inspection time increased dysplasia detection from targeted biopsies as well. In addition, we determined that for every additional minute of procedural time per centimeter of Barrett's esophagus, there was a 10% increase in dysplasia detection rate. For Barrett's length greater than 5 centimeters, 1 minute of additional procedural time led to a 25% improvement of the dysplasia detection rate. In summary, our study illustrates that longer procedural time during Barrett's esophagus surveillance improves diagnosis of Barrett's-related neoplasm. In order to maximize utility and efficiency of Barrett's surveillance, it is essential that adequate time slots are allocated for this indication. To allow sufficient time for inspection and performance of Seattle protocol biopsies, Barrett's surveillance time slots should be 30 minutes, increasing to 40 minutes for Barrett's length greater than 5 centimeters.
Thank you very much for your attention.